name is Dr. Chi Tan, consultant hematologist at the Royal Adelaide Hospital and SA Pathology. Today I'll be speaking about coagulation testing in the emergency department. Coagulation testing plays an important role in the assessment of a patient's ability to achieve hemostasis and to prevent blood loss. This is particularly useful with patients in the following settings. They are taking anticoagulants, facing major trauma or surgery, major and critical organ bleeding, including intracranial and gastrointestinal, suspected or known bleeding disorders such as hemophilia. Coagulation testing can also identify patients at risk of thrombotic events. It is important that testing is appropriate, as over-testing can result in inefficient usage of resources, interrupting patient flow, and prolonging patient stay unnecessarily. False positive results also lead to investigations and follow-up that adds further pressures on finite resources, increases costs, and risk of adverse effects to patients with unnecessary treatment. Initial coagulation testing usually consists of the prothrombin time, or PT, and activated partial thromboplastin time, or APTT. The PT evaluates the components of the extrinsic and common pathways of coagulation, specifically factors 7, 5, 10, 2, and fibrinogen. The APTT assesses the activities of the intrinsic and common pathways of coagulation, including factor 8, 9, 11, and 12, as well as 2, 5, 10, and fibrinogen. The INR, or International Normalized Ratio, is derived from the prothrombin time and ensures comparable results between laboratories using different reagents to measure the PT. It is a surrogate marker of the PT and is commonly reported with the PT. While factors which prolong the PT also prolong the INR, the primary purpose of the INR is to monitor patients on vitamin K antagonists, also known as VKAs, such as warfarin. The INR should be ordered in any patient on VKAs who comes through the emergency department with major trauma or bleeding, always planned for major surgery. The INR is also helpful in assessing compliance of patients to warfarin and also potential drug interactions with warfarin. A coagulation screen consisting of PT and APTT should be ordered in the following scenarios, many of which have been discussed previously. Patients with major bleeding, patients not on anticoagulants with a suspected or known bleeding disorder, patients with liver disease, patients with severe sepsis, patients with suspected disseminated intravascular coagulation or DIC, of which sepsis, malignancy, and pregnancy are risk factors. In these settings, particularly with suspicion of DIC, fibrinogen, thrombin time or TT, and D-dimer should also be ordered, along with FBC, which provides the platelet count and can indicate thrombocytopenia, which is a feature of DIC. A bleeding history is strongly recommended in assessing whether it's appropriate to proceed with coagulation testing and should be taken in patients with unexpected and/or excessive bleeding. Useful components of a bleeding history include history of liver or renal disease, both of which increase the risk of bleeding, family history of bleeding, sites of bleeding, i.e. mucocutaneous, musculoskeletal, soft tissue, intracranial, gastrointestinal. As a general guide, mucocutaneous bleeding suggests a platelet disorder. Musculoskeletal or soft tissue bleeding is a feature of coagulation factor deficiency, such as hemophilia. Triggers of bleeding, i.e. bleeding occurring spontaneously with minor or major surgery or with pregnancy and delivery. History of transfusion or inpatient hospital admissions as a result of bleeding, antiplatelet or anticoagulant therapy. Depending on which type of bleeding disorder is suspected or known, further laboratory testing can be requested. For example, for von Willebrand's disease, a von Willebrand's panel. For platelet disorder or dysfunction, a PFA 100 test, which is a screening test for platelet dysfunction, a von Willebrand's panel, and platelet lat transmission aggregometry. For hemophilia A, a factor 8 level. For hemophilia B, a factor 9 level. Specific coagulation factor and fibrinogen levels can also be requested. The direct oral anticoagulants, or DOACs, include the dabigatran, rivaroxaban, and apixaban, and are alternates to warfarin and are increasing in use. Specific coagulation tests can be ordered depending on which DOAC is being taken by the patient. The performance time, or PT, is prolonged in patients on rivaroxaban, whereas thrombin time, or TT, and APTT are prolonged in patients taking the dabigatran. Specific drug levels can also be requested for the DOACs. These are particularly helpful in major bleeding or trauma, or in patients facing emergency surgery. The APTT and PT are not sensitive to apixaban, and hence an apixaban specific level should be requested to gauge how much drug is on board. The provision of clinical information on the request form is critical for accurate interpretation of results. With patients on anticoagulants, please write down the type of anticoagulant, the dosage, and timing of last dose. When requesting a drug level for an anticoagulant, please specify the anticoagulant to be measured to ensure clarity. For example, rivaroxaban, apixaban, and enoxaparin are all measured by anti-factor 10A levels. Other details to mention on request forms include known liver or renal disease. Renal disease is particularly important with patients on DOACs, which rely on renal function for clearance. The known bleeding disorder, i.e. hemophilia A, von Willebrand's disease, factor 7 deficiency, etc. Write urgent if results are urgent, and please note if blood collection was difficult. All clinical details provided are useful, i.e. suspected sepsis, major bleeding or trauma, emergency surgery, cancer on chemotherapy, patient is pregnant, etc. Please ensure that coagulation testing is performed on citrate tubes, which have a light blue top, are adequately filled, appropriately labeled, and sent to the coagulation laboratory in a timely manner. Thank you for watching.